Okay, good afternoon, everyone. I'd like to welcome you to the sixth meeting of the Interim Joint Committee on Children. I would ask that you please silence your cell phones and would ask the Secretary to please call the roll.
Senator Rocky Adams, Senator Elkins,
Present.
Senator Girdler, Senator Harper Angel, Senator Mays Bledsoe, Senator Meredith, Senator Titchener, Senator Webb, Senator Westerfield, Senator Wise,
Present.
Representative Baker, Representative Banta,
Present.
Representative Kleins,
Here.
Representative Decker, Representative Dietz, Representative Elliott, Representative Fleming, Representative Gooch, Representative Proctor, Representative Raymond, Representative Riley, Representative Rorks,
Here.
Representative Wilner, Representative Wilson, Co-Chair Heverin, Co-Chair Carroll.
Here. We do have a quorum, and we shall move forward.
No, it wouldn't be.
Oh, okay. Ladies and gentlemen, we have a very intense agenda today, and we're going to start out first with the Kentucky. Oh, I'm sorry, we need to do the minutes. Everyone has the minutes from the October 25th meeting in your packet. Those in favor, please signify by saying aye. Opposed, no. Motion carries. Minutes are approved, and we will move forward now. The Kentucky External Child Fatality, Near Fatality Review Panel Annual Report. And I would ask Ms. Mahoney and Mr. Shannon to please come forward. And folks, you all have 15 minutes, and I apologize for rushing you today. And if there are issues that we need to address in a deeper manner, we can do that in a different meeting. Please introduce yourselves for the record, and you have the floor.
I'm Steve Shannon, the Executive Director of CARP, Association of 12 Mental Health Centers, and I serve on the panel.
Good afternoon, Alicia Mahoney. I'm an Executive Staff Advisor with the Justice and Public Safety Cabinet.
All right, go ahead. Firing up our PowerPoint. All right, we are representing the Child Fatality and Near Fatality External Review Panel. This is a group of 22 volunteers who review cases referred to us by Department of Public Health and DCBS. And that's a list of the composition of who serves on it. And if you look, our chair is a district court judge in Fayette County, Judge Murphy. We have Commissioner Dennis, who's here today. She serves on it as well from DCBS. DBH is Dr. Prada, and she's by proxy, so she is not the commissioner, but she serves on the panel. We have other judges. We have two people I always want to point out, Dr. Howard and Dr. Curry. They are pediatric forensic specialists. Didn't know that thing existed, but these are people who spend their career looking at bad things that happen to kids in the hospital setting. We have those. We also have the medical examiner. We have CASA representative, CMHC representative. We also have state police, so we have law enforcement. We have the coroner's office. Representative Heverin attended our meeting last month, I guess it was, the first time. We're glad to need a Senate member. I can recruit a Senate member.
I think I am that Senate member.
Sweet.
And I was not aware of that meeting.
Okay, we apologize for that, but we are glad you are there. So we need a licensed clinical social worker, family resource center, and we now have a addictionologist, Dr. Anderson, specializing in MAT treatment. So broad group. And what we do, we receive cases, as I said, DCBS and DBH, collect data. We have two staff that need to be pointed out, Joel Griffith and Cindy Kersinger. They are analysts. They review all the information for us. A lot of information, a lot of detailed information. Most of it is relatively unpleasant to look at. We then have an in-depth discussion, the 22 of us, on cases. Cases are divided by 4 groups, but you participate in all conversations. We try to categorize. We actually have 22 different categories that we can apply to cases, not just one per each, but multiple ones. And then we look at family characteristics. We really want to figure out what happens when we get cases. Why do those cases get to us? And obviously, I said this to Commissioner Dennis before we started, we're kind of the instant replay official. The play's over, it's done. Mr. Clark participated in our meeting one time. We go back and look at what happened. Sometimes it's kind of hard for us to do that. We want to understand it, and we really want to have a positive relationship with DCBS. Wasn't always that way. Sometimes it was contentious. We want to be honest, we want to be direct, but we want to be partners with DCBS and just not critical of what DCBS and their staff does. I contend it's the hardest job in state government, the DCBS caseworker. Said that before. A lot of tough work. Look at family characteristics. There are actually 51 family characteristics we consider, and then we look at the category and we make a determination. And there's about 13 of those. We want to understand what happened in these cases. We want to know what took place, so we're in a position to make recommendations, hopefully to prevent some similar events down the road. There'll always be more work to do, but we want to make those recommendations. Go ahead. So we have an annual report. We're going to look at case findings, case reviews, findings, and recommendations. So we have 3 recommendations, and we'll may go through quickly to get to our 15 minutes. Keep going. All right. These are significant for me. These are the ages of our cases, kids. And these are fatalities and near fatalities, right? A third of the cases are less than 1 year old. We're talking 6 months, 9 months, 10 months. A third of the 215 are less than a year old. Another third is 1 to 4 year old. 2 out of 3 cases we look at are less than 4 years old. These are really, really young kids who can't defend themselves. That's what we're looking at, 2 out of 3 cases. And then the rest, as you get older, the 15 to 17-year-olds, suicide comes into play, overdose comes into play, middle school as well. But it's really those young kids. An infant. Who's hurting a 10-month-old? Who's threatened by a 10-month-old? Scary stuff, in my opinion. Keep going. All right, key findings. Again, this is where 21. We're still gathering 22 data to finalize it. We get the cases after they've been reviewed by DCBS, so they're not like real time for us, but we get them and look at them. COVID. And COVID was significant primarily. Kids weren't going to school, right? Court cases, hearings were all virtual. Even family visits were virtual. So you didn't get eyeballs on kids. So COVID was really an issue in 73% of those cases, the 215. Real issue. Financial issues. Families struggle. We don't know their income, but we do know if they have K-CHIP. We do know if they have SNAP benefits. So we assume financial issues is a challenge. DCBS history. 7 out of 10 cases had a previous interaction with DCBS. 7 out of 10. Substance abuse, caregiver. And a caregiver is a responsible adult. That's important to realize. The caregiver is a responsible adult. Half of the cases involve substance abuse. Criminal history, again, half have some previous. This isn't, speeding, traffic violations. These are involvement with the criminal justice system, half of those. Almost half is mental health systems. 91% of blunt force traumas, one of our categories, car accidents, motor vehicle accidents, impaired caregiver, an impaired responsible adult, right? Physical abuse involves caregivers with criminal history. This is why it matters. We want to understand this and maybe identify things down the road. Abusive head trauma, substance abuse, and criminal history. 90% of youth suicides involve unsafe access to deadly means. Unsafe access to deadly means medications, drugs, illicit and prescribed, are not adequately secured at the home. And we'll see more about that later. Other is guns. They're not put away, they're not secure, they're not someplace else where kids can access those. Next, family, this is a recommendation, family recovery court. Some states have these. We have a couple pieces. I looked online. We have a couple that maybe got grants to do these, and they're in the developmental stage. It used to be family drug court. We changed to family recovery court because we want to focus on recovery. Now, we want to make sure the kid's all right, but we want to provide those services to families, whether it's job assistance, it's therapy, group individual therapy, maybe intensive outpatient services for substance abuse. But support the family, other life skills, how to get a job, how to keep a job. And if you look at these, 72% of the fatalities, right, 72% of those had prior involvement with the court system. 2/3 of near fatalities, and overall about 68%. So we have involvement with the court system. This we think is an approach as a recommendation moving forward to address some of those things early on, the initial contact with the court system, and really help the family be in a position to move forward. Now we're looking at co-occurring. These are things that the blue line is all cases. The orange, I think that's orange. I'm not very good with my colors. Our prior court history. And if you look at these, DCBS history, 82% of those folks have DCBS in court history, 8 out of 10. We know who these people are. We've interacted with them. Financial issues, 80%. Right? A lot of that, I would say, is housing. Sleeping on sofas, moving around. Child care. A lot of people give their kids to someone to take care of while they go work that second shift at Arby's for not a lot of money, and it's not always a good choice. A paramour takes care of kids, and not very good. Mental health issues, half of those, over half, right? Domestic violence, huge issue, right? Right, got to pay attention to these things. Our goal is to identify what can we do going forward. Criminal history and substance abuse. 6 out of 10 have substance abuse. Not a surprise, I don't think, by anybody. Go ahead. In utero drug exposure. This is plan of safe care. What we are recommending that, and we made this recommendation to the Department of Behavioral Health. They're looking into it. How do we get the services in collaboration with public health to look at those babies that test positive at birth? Okay? So we know, because that family is going to need support. And this is just a breakdown. Cannabinoid, marijuana and such, 31%. It's a problem. We have to understand it. And it may expand over time. Methamphetamines, MAT. Now, MAT, if they're prescribed by a doctor, right, and they're taking it as prescribed, we're still tracking that. We want to know that. There's a lot of cases where they're not prescribed MAT, buprenorphine primarily, and they're getting that some other way and taking it, and that's a problem. All heard about fentanyl, benzos, cocaine, heroin. All right, these are things babies have tested positive for. Go ahead. So we're recommending that they accept Department of Behavioral Health look into this to develop a plan of safe care so we know what happens, so we can get involved with that family early to prevent the substance abuse, provide those services that will ideally create a stable housing situation. They have a place to stay, get mom and dad jobs so they can support their family and go on from there. DCBS should notify. The challenge we've had, and we have a subcommittee looking at this, and other groups have subcommittees, is they may test positive in the hospital, mom and baby go home, and there's no connection. What I do for a living, I spend a lot of time talking about warm handoffs, and we have not mastered the warm handoff. We're not very effective at doing that. So this is an approach. Can we make sure that those folks who need that connection is made, and they access those services? Health and Welfare Committee, this is an old recommendation. It no longer exists. I'd put appropriation revenue in here, funding to implement the plan of safe care. We need to move forward and make sure this takes place. Go ahead. These are some trends. Overdose and ingestion. These are some kids find medications in their home. It speaks to me about they're not secure, they're not paying attention. We had many cases where mom or dad takes buprenorphine and they emptied their pockets and it was on the counter. They thought the stuff was secure on top of the fridge, and the kid climbed up and got off the fridge. We got to do better taking care of this stuff, but we have recommendations for that. But if you look, there you go. This is what's been ingested. Can't keep up with my opioids, clearly fentanyl, Suboxone, methadone. These are kids taking this stuff, right? They're not prescribed. They find it and take it. You can see all the lists. And again, they're not prescribed these. They're getting these and taking them. Someone in the house, the caregiver, someone, an adult in the house, have these in their possession, and the kids find them and take them. Go ahead. You're doing good. Recommendation. These are safe boxes, right? Safe storage for medications. We've given out, I think, about 8,000 of these, right? My opinion, we should give out 80,000, 800,000. Any case, people have these, and that's exactly what the box looks like. Locked, secured. And this is a problem we hear regularly. They thought it was put away. They thought it was in a safe place. They didn't think the kid knew about it. We're passing those out to anybody who wants one. They call, somebody wants one. We make it available. They actually have, UK has bags. Same idea. Instead of a case, it's a bag. But it can be locked and put someplace where kids can't get into it and take medication. Go ahead.
A couple minutes, Steve.
All right. We're almost done. Suicides. Big jump, 8 to 12. And again, I'll be in trouble if I don't say this. These are only the cases we receive. This isn't all the suicides. These are the ones that make it to our panel, and you look from 8 to 12, right? 10, 8, 12. These are cases we review. This is looking at the youth suicide. Again, the 12 cases most recently. Males, 5 gunshots, right? 2 girls, gunshots, 5 overdoses. We got to keep stuff put away safely. Go ahead. So part of the recommendation we have is a thing that some places are doing. We have some people in Kentucky who can do this. It's a psychological autopsy. Okay? I don't like autopsy because it's after the fact. I like people proactive. But this looks at what happened. Can we figure out from who the child, what they said, who they interacted with, what was going on before their suicide, and learn more about to take a preventive approach to that. So psychological autopsy. Not really widespread, but we need to move towards it. Other places are doing this. The cost, maybe there's a grant to pay for it, but start working on it. I think part of it, from a provider perspective, if it's not something that is clearly billable and you can do, it's not on a fee schedule, you're less likely to train people in psychological autopsy. But I think we need to get to that place. Go ahead. So child access prevention laws, firearm-related injuries, okay? Gunshots, suicide, accidental, and homicide. And it's really kids find guns and play with guns. Some suicide, go find a gun and do something else. But we need to make sure, and our position is prevent access. We're not making this up, we don't want to be perceived as in a gun, right? We just want to make sure they're put away and they're secure. We had cases last month with the gun was in the dad's car. Kid got in the car and played. You got to put it someplace else. You got to put it secure. You got to put it away. Go ahead. That's it. How'd I do?
Excellent. Questions? Senator Meredith?
Thank you, Mr. Chair. Thank you, Steve, for the information. I'm looking at your slide, comparison of co-occurring issues.
Yes.
All panels compared to cases with prior court history.
Yeah.
Can you elaborate on the DCBS history?
The DCBS history may very well involve they had a previous referral, they had a case that wasn't substantiated. Someone called and said something's going on, so they have a record of an interaction, but it wasn't necessarily taken up by DCBS. Some have open cases at DCBS. And it goes back 5 years. So beyond 61 months, we don't pay attention. It's the previous 5 years. So it may have happened 4 years ago.
Yeah.
We decided to have a very broad net, not more specific.
I'm sure that's a factor, I guess, so it's kind of hard to quantify it since you really don't know substance to it. So it's really just possible notification of DCBS was driving it. And the last, and I know you probably can anticipate I'm going to ask this question, but can you break this down, urban versus rural?
We can. I have not. I should have thought of that before I got here today.
Well, it's multi-factoid, and what drives me with that question is you look at the financial issues. And
yes.
Poverty is usually.
Yes.
And it's just something I'm always interested in.
We try, and we know where it was. We were advised at one point, don't put the county down because some of these are still in prosecution. So we want to kind of keep a distance so we don't interfere with that process. But we have an idea where people are at and what happens, and some are clearly, by the office. But it's. I would like to tell you it's one or the other, but it's not. The cases are all sorts of play. I mean, it's. I mean, I've been there for 5-6 years. I don't know if we had cases from every county, but I bet we have cases from 2/3 of counties in the state, 80 to 100 counties. So.
Well, financial covers a lot of territory, and I'm just curious to see what this is going to look like post-COVID.
Yeah.
Because I believe that you're seeing a real deterioration of family household incomes and whether that's going to impact this or not. And again, I think it's important from an urban rural perspective to take a look at that. But so many things that we deal with in this committee and health services as well, or even judiciary, are driven
by. We actually have, and we can get this to you, all counties listed, right? So pick a county, I can tell you. In 14 to 20, Menifee County had 1 case. Cumberland County had 1. Davies had 34. Fayette had 40. Jefferson, where's my J? There, I can see it. There it is, 208. You have a total of 1,000 cases. And 20% in Jefferson County is probably not that far off from a percent of population. Maybe a little bit higher than you anticipate.
Well, when you look at raw numbers like that, certainly, but I think, per capita may be of more value to us, and it's got a long-term.
We can do that. We can
I
break it down by
appreciate that,
county. Yeah.
But again, I would hope that we really focus on poverty in Kentucky. I made this comment yesterday. I wish we would attack it as viciously and as focused as we did in the COVID pandemic, because I think the implications of poverty are much worse than
Poor is
COVID.
really bad.
But thank you. Thank you,
Poor is
Mr.
really
Chair.
hard.
Thank you. Representative Rourke, you'll have the final question.
Thank you. Just want to ask a brief clarifying question. In the report, does this include all cases, or is this just a sample size of the cases?
This includes the cases we receive,
Okay.
the panel receives, not all cases. So there's the ones that make it to the panel either through the Department of Community-Based Services or the Department of Public Health.
And what cases, like, how does that determine which cases are seen versus which ones
My
are not?
expert answer.
So they have to be suspected of abuse or neglect. So they have to be fatality or near fatality, and there has to be a suspicion of abuse or neglect.
And that near fatality and fatality is determined by a physician, right?
The near fatalities are determined by a physician, yes, and that's by statute.
One brief follow-up, if that's okay. Yep. In terms of what's reviewed, does it include both gun deaths and gunshot wounds?
Yes.
Okay. Thanks.
Yep.
All right, thank you.
y'all.
Co-Chair Hebron, you want to close this out, please?
I do. I just want to thank you all for your work on this. It's very heartbreaking, and it's not for the faint of heart. Until I was recently appointed to the panel, I had no idea. And it is, I think with every case I read, I cried. And it's just a lot. It's a lot that our kids endure. And even the ones, it is the, if they are able to survive, it's the trauma they deal with afterwards.
Yes.
And so I appreciate what you all do to lift this up in the Commonwealth and your heart to give policy recommendations to us. So thank you for your service to this committee, and I look forward to working with you all on policy decisions.
Super. Thank you all.
As do I. Thank you both for
Yep.
being here.
I'll be reaching out to you, Senator Carroll.
Okay, very good. Secretary Friedlander, if you and your staff want to step forward, or if it's just you. Members of the committee, you all know in the last meeting we talked about the groups of kids we have in our state, those that are being with mental illness that are being housed in detention centers, in cells, those that are being shipped out of state, those that are spending the night at DCBS offices. So today's meeting is all about those kids and really nothing more. We're going to ask Secretary Friedlander to kind of define who these kids are, so in our minds we understand what we're dealing with. And then we're going to have various providers to come forward and to talk about what services they offer, what their capacity is, so we can kind of get a snapshot on what the need is and then what the capacity the state has to serve these kids. The bottom line being, we've got to come up with a solution for this. We've got to get kids out of DJJ detention facilities. We've got to get kids back in our state, and we've got to get kids out of DCBS offices. And that's what today is all about. And I'm going to ask that please hold your questions until we hear all the testimony. And I'm also going to ask the providers, when you come forward, this is not the time to pitch for funding. This is not the time to talk about all the programs that you have. This is very specific. We have 10 different providers here today, so we need to know what your capacity is, what population you serve, what the struggles that you have are with staffing, in hopes that before we leave this annex today, that we're going to have a plan in motion to solve this issue. And I've said before, this is embarrassing to the state. This is way beyond embarrassing. This is a travesty, and this is the most urgent issue I feel that we're facing in this state today, and we have to get this resolved. And ladies and gentlemen of this committee, it's going to start with us today. So thank you all for being here. Mr. Secretary, please introduce yourself for the record, and you all have the floor.
Thank you. Eric Friedlander, Secretary of the Cabinet for Health and Family Services.
Good afternoon. Lisa Dennis, Commissioner for DCBS.
So I'm going to try to paint a picture of the kids. Actually, some of these kids probably are represented in the previous report. But here's who we see. Some of the kids that come into this non-traditional placement are kids who have disrupted placement, which means something happened in the placement and they're with us for a day or two. These are actually not the high acuity kids necessarily. These are kids who are between placement, and it may be a day, it may be a day or two, and we're working on some emergency shelter pieces, and hopefully we'll be able to minimize that. The kids that are really difficult, and these are the kids that you see in news reports. Kid in Northern Kentucky, there's a kid in Jefferson County or two in Jefferson County. Who these kids are the kids that we can't get placement for, that end up out of state, that end up in DCBS offices for longer periods of time than anyone should feel comfortable with. These kids are kids that have had usually multiple traumas, kids that have behavioral health issues, kids that have developmental or intellectual delays, kids that end up on the spectrum of autism, or kids who have acted out sexually and who are reactive in that way. I think some of those news reports have alluded to that. Kids who have acted out aggressively against staff, where they may have hit staff, been in altercations with staff. Those kids are the kids that we have the most difficulty placing. We may have asked in-state placement hundreds of requests, even out-of-state placement sometimes, hundreds of requests on the same kid. Those kids that are still sitting in our offices, those kids, hundreds of different requests. There was a recent WDRB report, right? That is the kid, right? That is so very difficult to place. Facilities, and rightfully so, get worried about their liability, get worried about workers' compensation, get worried about what's going to happen in their facilities and their therapeutic environment. These are such specialized kids, and the care that they need, and it's one-to-one staffing, or really what's happening in DCBS, it's 2-to-1 staffing, maybe 3-to-1 staffing, meaning 3 staff folks working with 1 child. That gets very difficult, and you can't place a child like that in a big unit, in a big facility. These kids need such individualized attention that it gets very difficult to find placement. Our highest level of care, children's psychiatric acute hospitals, feel like they can't appropriately care for some of these children. Some of these children then end up out of state, and that number's been going up, and it has. And that's because you have specialized units, a series of specialized units, kids with autism, kids who are sexually reactive, there's such specialization that we don't actually have that type of care in Kentucky. We've asked for it. We've tried several different ways. I think I've testified about the different ways we've tried to do it, with RFPs, with individual case rates, all sorts of different things that we haven't quite been able to come together on. And that's true. That's true. So I appreciate your urgency. I appreciate this committee's urgency. It's a tragedy. And it puts our social workers in tough positions. It puts the kids in tough positions. And if I may, just for a second, just to go beyond the kids for just a second. Social workers who are volunteering in 4-hour shifts to take care of these kids, to care for these kids, I can't begin to thank them enough for their dedication. I may have told this story before, but I want to tell it one other time. We had a kid who got an out-of-state placement, and the kid and the staff had become attached because they had been together long enough that the kid who was going to be in an out-of-state placement said, "I hope you can come visit me on my birthday." That's the kind of over and above the staff have done. And and we need to make sure that we can stay connected in that case. But that's the kind of thing that we're seeing. And I, again, want to assure everybody, we've tried several different things. And so, again, I appreciate your all's commitment and sense of urgency around this. I appreciate our partners. But we have a lot of work to do. And I know you said it's, maybe we're not talking financial at this point, but I think we've got a whole system we need to look at. Because I think there are things we need to come up with together to really make that difference. Commissioner Lee, Lisa, would you? Sorry.
I agree with everything the Secretary has stated. And again, we just want to reemphasize the work that our DCBS social workers have done to provide care for these kids. They have gone above and beyond, and I can't again thank them enough. A lot of these youth are very attached to our workers, and we see that. So what we've been seeing is that the need for individualized care for each of these kids. It's not that it's one size fits all. This is a very unique group of children who each need something different from the system, and so finding that has been the challenge. So nothing really else to add.
Yeah. Okay, Secretary, I want to make sure I understand. So most of the kids that we're seeing that are spending the nights in DCBS offices, those are kids that have more emotional behavior, that type of thing that are difficult to place. These aren't kids that have just been removed from a family or anything of that nature. There's a lot more to it than that for those kids. Correct?
There is occasionally a kid that because of a removal or between placements may come in for an evening, but that's like one, okay. Right? And that's not. That's happened for a while when you can't find. It's midnight on Saturday, right? That's the kind of example I would give you.
Okay. And do you have numbers for each category of kid? How many?
Yes.
Many do we have in DJJ facilities right now? How many in Secretary Harvey? Yeah. I may have to get that from you.
Yeah. And yeah, we get that from Secretary Harvey. But here's the thing: the kids in Secretary Harvey's system are the same kids that are in our system. It honestly just depends on whose custody they're in at the time, whether they're in DCBS custody or DJJ custody. Okay. Their kids are our kids are their kids. It's the same issue.
Help give us some numbers, though. I understand, like out-of-state placements, we have about 80 something, Secretary Friedlander. We have about 80 out of state.
We have 38 out of state for treatment.
Okay.
So and then we have referred up to I think 88 or 90 some kids for out of state placement. But right now, currently, we have 38 that are out of state for treatment purposes. Now we have some other kids that are placed out of state. You may see that on our fact sheet, but that is kids that are placed with relatives and other settings. But for the treatment piece, it's 38.
And let me say one thing about out of state, if I may. Occasionally, it's right. Occasionally, that's the right placement. I think an example of one of the folks in your system, that person was actually successful in an out-of-state placement, and we said, well, let's not have anybody out of state, and we kind of disrupted her placement. So occasionally, it's right. I don't know what the right number is, but sometimes in that very, very small specialty, and if a kid is being successful, sometimes, very rarely, it's the right thing.
Okay. And as far as those that are in psychiatric hospitals right now, do you have a number on those?
As of October the 1st, we had 115 children that were committed to DCBS and psych hospitals.
And we can provide the committee with these numbers, and it'll be as of a specific date.
Okay, I didn't see that. Secretary Harvey, would you please introduce yourself for the record, please?
Yes, I'm Kerry Harvey. I'm the Secretary of the Justice and Public Safety Cabinet.
And how many, do you know how many we have right now within confines of detention facilities within DJJ?
And really, Chairman, it depends. I think first we have to kind of reach the definition issue. A lot of the kids that Secretary Friedlander talked about are not the kids that end up in detention as a last resort. I think if you think of acuity in concentric circles, the kids that I would talk to you about are in the inner ring of the concentric circle. These are kids that will never be sleeping in a DCBS office because the DCBS worker would be in danger. The kids that we see, and fortunately there's not that many of them, at any given time there's probably fewer than 5, but the kind of kids that end up in detention centers as a last resort, which should never happen, are kids who are so severely mentally ill that they are just hyper violent. And I think what happens is when they're in their homes, when they're in their communities, because of their untreated mental illness, they're violent. So they commit assaults, they commit crimes. They go in front of a juvenile court judge who really has no option but to put them in a juvenile detention center, which of course is the worst option. So when we get these kids in a juvenile detention center, anytime it's just virtually impossible to mix them with the other youth in the center because the other youth are going to be endangered. The kid's going to be endangered. Our staff is going to be endangered. And so we end up with this horrible situation where we have severely ill children who sit in a detention center really with no meaningful treatment. Our juvenile justice folks, we have some psychologists, we have some resources, and they do their best with them, but that is wholly insufficient for kids who are actively psychotic, for kids who have such severe mental illness that they're going to be committing acts of violence anytime they're around other people. So that's a little bit different than some of the kids that Secretary Friedlander's talking about. As I say, fortunately, at least in my experience, it's not like we have 50 of those kids at a time, but we might have 2 or 3 or 4. But every one of them is a tragedy, and every one of them deserves to have medical treatment because they're sick.
And that violence and that escalation of violence, those kids may have started with DCBS, and because of our system's failures, end up in Carey's system.
And if I could just piggyback one more thought on what Secretary Friedlander said, some of these kids that I just described, we feel blessed if we find an out-of-state facility that will take them and treat them. And we have had kids, in my experience, we've found out-of-state facilities that, or in-state facilities that say, yes, we'll admit this child, we'll treat this child, but when the child is there to be admitted, they become very violent. They attack the staff of the facility, and the facility, understandably, I cast no blame on them, because they've got to protect their staff, they've got to protect the other patients they work with. They say, I'm sorry, but we can't accept a child who exhibits this level of violence.
Any questions related to the population that we're talking about at all? If not, we need to move forward. Okay. Thank you all very much. I appreciate it. First, we're going to ask representatives from the University of Louisville Health, Andrea Lewis, the CEO of Peace Hospital, and Ken Marshall, the COO of University of Louisville Health. Please introduce yourselves for the record, and 10 minutes, please.
Hi, I'm Andrea Lewis, the CEO of U of L Peace Hospital.
And I'm Ken Marshall. I'm the Chief Operating Officer at U of L Health. Thank you for the opportunity for us to talk about this issue. And I think what we wanted to get across, and Andrea will go into detail on this, is not only what we at U of L Health and specifically at Peace Hospital currently offer to the age population that we're talking about, but also I think in the end I hope you get to understand that I think there's no one who wishes that this was a simple problem to solve more than us. But we do recognize that given the complexity that Secretary Friedlander just outlined, I don't think we're going to come to a solution that is going to be really simple to implement. I think this will be a collaborative solution, and we are ready to stand by and provide what services we are really good at to address this problem. And if there are other ways that we can change and be helped to solve this, we stand ready to do that. So I'll let Andrea go into the details of kind of what we provide.
Alrighty, so next slide. So Peace Hospital currently assesses adolescents that are detained at youth detention centers or on diversion, and we often admit those refused in other facilities. Currently, I can tell you we have 2 females from one of our juvenile detention centers who are waiting right now for beds to admit that need psychiatric services. We've been a partner in finding solutions after discussing with KHA, and we also work with Aetna Better Health because they have the SKY program for children of the custody of the state. Approximately 50% of our child and adolescents are in state custody. So we have 57 kids today out of the 115 that they just referenced are at Peace Hospital. So we are a partner, and I want you to hear that as well. Over the past couple of months, we've averaged about 53 inpatients per day of kids in DCBS custody. 30% of these kids require either a one-to-one staffing and or a single or a blocked room, which means they either have high aggression or high sexual acting out behavior to the point where they cannot have a roommate. So because of that, we have to be very careful to protect the other patients there at Peace Hospital. We have 12 kids that have been there greater than 90 days. Some have been there almost 400 days. So we are a partner. We definitely want to find a solution. And this, the longer these kids stay, even at Peace Hospital, sometimes the behaviors get worse when they have nothing to look forward to. Under current challenges, under safety, of course, environmental, there would need to be infrastructure that would help with property for these patients that we're talking about that need a place. Staff, reduction of worker and high rates of injury in light duty employees. We did pull our injury report, and we average about 30 staff injuries per month, and 3/4 of those are due to managements or aggression. As far as patients, as they talked earlier, we cannot, compromise the safety of our patients that already are on site at Peace Hospital by putting them in with roommates with high aggression, et cetera. So we have to be very careful who we mix as far as children, adolescents, et cetera. And then we also review multiple incidents per week on incidents of sexual acting out, physical aggression, and self-injurious behavior. Staffing, as you mentioned to discuss, some of these patients require, there's times we've had 2-to-1s at Peace Hospital, 2 staff to 1 patient for 24 hours a day. We currently have 46 mental health full-time positions for mental health workers, which is entry level. They're the ones who do the safety checks. We have 35 full-time vacant RN positions. Now, keep in mind, I have a 261-bed hospital, so it's 11 nursing units. But also competency, just the skill set and training and making sure that we're reducing injury and keeping our staff and patients safe is paramount here at Peace Hospital. And then our last slide, we wanted to say that we are part of the solution. The children of the Commonwealth are our priority as well. We are committed. I talk to Dr. Lohr probably monthly. We have regular calls with difficult to place kids calls as far as updating the forms, trying to see if we get a month of better behavior to send out for placement. We work really hard with the DCBS team, Dave Gutierrez. We are constantly meeting to see what we can do for these long to stay kids at Peace Hospital. And we do think partnering with KHA would be a solution. I know the psych CD form meets quarterly, and I just joined a few months ago, but prior to that, they had a proposal. They were looking at something where we probably need to dust off that proposal and talk about a different level of care, because what we're looking at is we're like the med-surg hospital, or we're like the basic level, and then we're talking about some of these DJJ kids, juvenile justice, that are higher level of care, and they need more staffing. So that is something we need to consider, as well as a physical location and an infrastructure that would reduce and facilitate safety, And we definitely want to partner with our partners behind us and see to leverage our strengths and weaknesses. For example, Peace Hospital has 3 units dedicated with kids that have autism, developmental delays. These kids require a lot more staff, a lot more one-on-ones, and we use applied behavioral analysis. So that's something we could leverage with some of the kids that need help. We definitely would love to lend our services. We partnered recently with UK. They opened up a children's psych unit. They came down to Peace Hospital to tour and get information. So anything we can do to support, we'll be happy to be at the table as well. Thank you.
Okay, thank you all so much. I'm assuming you all will be staying in case we have questions. Okay,
yes,
thank
definitely.
You.
Thank you.
Okay, next presenter, Jason Statz, the CEO of Sun Kentucky. Sir, if you would please come forward and introduce yourself for the record, and you have the floor.
Hi, Jason Statz, CEO for Sun Kentucky. I wanted to say thank you for the opportunity to speak here. I joined Sun in April of this year, and I was really quickly oriented to the ongoing concern that meets this population. And when asked to speak on our current and future preparedness, I wanted to try to articulate where we sit currently with the services we provide and what we could in the future be able to develop. Currently, similar to Peace Hospital, we don't have this specific programming to different populations in the specific niche populations that Peace Hospital has. We have general population units, and we've been able to, at this point, assist with these cases as one-off in our general population units and programming them along with the inpatient stay. But typical inpatient hospitalization is 5 to 7 to 14 days, a relatively short stay, because it's designed to address acute exacerbations of the mental health or psychiatric symptoms, and we stabilize, and the program is designed to get them reintegrated with the community fairly soon. And we've been able to admit on a one-off basis some of the kids that are on the higher acuity of that spectrum into the general population, but we've learned that it really disrupts and pulls the treatment away from the general population. So we are in the process of looking at programming. We've learned a lot from Peace Hospital and what they're doing with their populations, because it does look like these kids need more of the long-term behavioral modification, and as she was saying with the behavioral analyst and psychological interventions, as opposed to the psychiatric crisis stabilization that most of our patients are in need of. So I was oriented to the proposal that the KHA had worked on last year. I think it was October of 22, with the hospitals in Kentucky, to look at what does the psych equivalent to an LTAC look like, the longer-term acute hospital, and do we have the capacity to do that in our hospitals that we have? Some hospitals are better situated than others with the physical environment where they can section off smaller units. As Secretary Freelander was right on the description of that, they don't do well in big populations because they need very specific, very focused programming. So not every hospital has the ability to design a population that small. So where I would say we are currently, we have partnered with many of the people that are here today to speak. Peace Hospital as an overflow to them if needed, and Holly Hill and DCBS. And I can say that my experience so far with DCBS on the cases that we've worked with, they are very invested and very present in the discussion of what's happening after discharge, but oftentimes there are no options. And so and when kids get stuck in a inpatient level of care that's designed for a few days and they're there for months on end, it really impacts their overall stability and starts to regress. So I hope that gives somewhat of a picture of the acute phase that we are able to help with. We do treat a fair number of DCBS cases on a short-term acute basis, and very much interested in continued work with the Hospital Association group, the Psych and CD Forum, to be able to look and design something for the needs of these kids specifically. but that was my intent, to talk about current and future capability.
Very good, Mr. Stats. Thank you so much for being here, and would ask you please hang around. Mark Birdwhistle, Senior Vice President and Chief Administrative Officer, UK Healthcare. Mark, please introduce yourself for the record, and you have the floor.
So, good afternoon. My name is Mark Birdwhistle. I'm Chief Administrative Officer of UK Healthcare. I will have to say, before I get into my formal remarks, having served as the former Secretary of the Cabinet for Health and Families, I had a great deal of empathy for Secretary Freelander, Secretary Harvey, sitting at this table. We had similar problems when I was Secretary, and I think what we're doing today is a good first step. What my recommendation is that this takes a big table solution. This is a very complex problem. Not any one of us can solve it. It's going to take us all working together. So from a UK standpoint, I've talked to a lot of our experts over the past several weeks. I think there's things that can be brought to the table. I will point out, unlike our colleagues at U of L, UK does not have a facility or the infrastructure to bring to bear for this solution. What we do have are experts in the fields. We have within the College of Medicine, we have the UK Center for Children and Trauma, who do research, who help us figure out what is right, what can be done. We've got leadership in the College of Social Work. We've got leadership in the Department of Psychiatry. We have pieces and parts that could be plugged into an overall master solution. Listening to the conversation both from my experts at UK and from the Cabinet today, it does appear that we may not have this level of care in the state of Kentucky to meet this specific need. If we're sending 38 out of state, we probably need to look at what is that facility, where they're located, what are they licensed as, and are there things we could learn from that? Now, I'm not sure UK needs to own it or operate it. Where we come into bear, our expertise is providing advanced subspecialty medical care for the Commonwealth. We're focusing on transplants, we're focusing on cancer. But we do bring some experts to the table, and my recommendation is that we use those experts and plug them in as we re-envision what does foster care look like, what is the reimbursement rates for foster care, are there ways that we can infuse some additional training to the foster care parents so that things could be identified earlier and that we could track these kids to the most appropriate setting as soon as possible. So I think I would sum up what I'm trying to say is what UK can bring to the table is expertise. We can help in the training, we can help in the research as why is this happening, where is it happening, kind of drill down into it so that we can figure out how to attack it. And then we have clinical expertise that I talked about a second ago in our various disciplines, and we stand ready to bring this expertise to the Cabinet and to the Commonwealth because that's what we do.
Thank you so much. Next, we have Abrielle. I hope I pronounced that correctly. Drain is the president and CEO of Bellwood and Brooklawn. Ma'am, please introduce yourself for the record, and you have the floor.
Thank you, Chairman Carroll and Co-Chairman Hevron and the committee. My name is Abby Drain. I'm President and CEO of Bellwood and Brooklawn. A little background, Bellwood and Brooklawn have been caring for kids for over 170 years. We have facilities in Lexington, or care for kids in Lexington, Louisville, Anchorage, and Bowling Green. We provide child psychiatric residential, qualified residential treatment, therapeutic foster care, independent living, and family preservation. I've been the CEO there since 2014, and prior to that I was their CFO at Brooklawn. I have over 31 years experience in behavioral health in the financial and executive areas. My other years were in community mental health center. We're here today at your invitation to talk about our psychiatric residential treatment facility. This is just a definition. You probably all know about that, but the intense level of psychiatric residential treatment. And it is for adolescents with significant intellectual and potential to respond to active treatment, for whom outpatient treatment, partial hospitalization, or protected instruction environment is medically or psychologically necessary. Brooklawn was the first psychiatric residential treatment facility in Kentucky. Actually, the CEO at that time, David Graves, got together with DCBS and Medicaid, licensure Tom Birch, Margaret Pennington, some names you might know, and they worked together to establish the PRTF level of care for kids that, like we're trying to do today, were not served, and there was a hole. They were being backed up in psychiatric hospitals, and there was no payment source for this, for the kids. But this psychiatric level of treatment, residential level of treatment, saved a lot of money for the state and took care of some kids. I think today we pay over $2,500 for a psychiatric day of treatment in a hospital. And out of state, maybe $1,200 to $1,300 a day, and we provide this service and have for $300 a day until the last couple of months when they've raised it to $500 a day. Brooklawn has 6 cottages that are licensed at a PRTF level 1, and we hold 2 certificate of needs that we'd like to act on for a PRTF level 2. In a PRTF level 1, they're limited to 9 beds per cottage. They're gender-specific cottages, and they're children in a similar age range. And if you get to a certain age, we look at size also to make sure the kids are safe. We're accredited by the Joint Commission as one of the hospital levels of accreditation. Right now, Brooklawn has 36 licenses that are in a hold status, pending status, and this is how we came about that. In April of 22, CMO imposed an immediate jeopardy status on one of our cottages, and by September, that very next month, they released that based on our corrective action plan. And we still remain in good standing with our Joint Commission who looked into our death on campus. DCBS ceased those admissions to our qualified residential treatment program beds, which are 100 and some other beds that we have, in July of 22, but they opened admissions back up in May of 23. During that time, we still continued to take care of DCBS children. We just weren't allowed to admit any other children. Bellwood and Brooklawn continued to care for those 100 children during the probationary period and had no incidents. Brooklawn was closely monitored by DCBS during June and July of 23 with weekly status updates, and no issues were reported. Licensure appeal has been pending since January of 23. Of the 171 PRTF beds that are in the 2022 utilization report, 63 are closed. That's 38%. And 36 are on hold by the cabinet. Those are our beds. Recent closures are listed, and our license been on hold since January of 2023 when we submitted a response to appeal. There are 4 cottages. 1 cottage was closed due to a death of a child, and 3 cottages that's 27 beds, are closed due to a few unrelated self-reported citations from years past. We have submitted a robust plan of correction that includes a best care model of care developed by the National Association of State Mental Health Program Directors. We submitted that in December 22nd, but revised it in March of 23 because we hadn't heard back from the cabinet and we had some more pieces and parts that we'd put together and been able to be successful at. We've implemented 6 core strategies, which is a program to reduce and eliminate physical holds. We have very few holds on our campuses now. All our training used to go into how to hold a child, and now it goes into how really not to hold a child and what you do in advance of that. And I think all the residential programs in our state are doing that now based on our loss in 2022. We've had hundreds of hours of training. We've overhauled our policies and procedures, and we've had significant capital investment in our facilities while children have not been there to improve our facilities. It's really hard to paint and replace cabinets and kitchens when you have kids 24/7. This is a graph of our psychiatric bed capacity from January 22nd until September of 23. You can see that our capacity is underutilized because those beds are on hold. I want you to know from the time that I've been around, 2011, until January of 2022, we were at 95% capacity of our PRTF beds and been very successful of that. But based on our death and the closing, that has swiftly declined. Right now we have 18 beds open. You'll see some numbers like 20 and 19. That means a kid left and another came in during that month. And we're doing really well taking care of those kids. We've put a major fence up around campus. It's a 6-foot beautiful black fence that was really in the plans for 7 years because people would come on our campus and break in our cars and steal things. But it's really been great for kids not running. They don't even think about running because of the fence now, which is nice, and it's nice for the community as well. I also wanted to report on our total campus. We have 2 total campuses, 150 beds, and you can see the bed capacity and the utilization and how it's declined. And that's as we took care of kids that were left in our custody last year and continued to care for them. We have lost over $2 million doing that. I have a financial background and know how this is. We've lost most of our staff. And we're going through a whole new retraining. We were collaborating with another entity that also faced some legal challenges during the death of our child. So we have separated from that company and are building back the entire structure of Bellwood and Brooklawn. What we want to do, we're prepared to serve the additional children. We have that expertise at taking care of those older children. That would be what you'd say that our niche is, the older, mainly male children who have significant issues in staying stabilized in placements and have acting out episodes. These are children that people don't want to foster and don't want to adopt, but Bellwood and Brooklawn has always taken care of those children, and we want to continue to do that. Thank you. Are there any questions?
We're going to hold questions to the end. Thank you so much for your testimony. Next, we're going to ask, and Representative Fleming, please take note of your question, and we'll get to it here shortly. Michelle Sanborn, President of the Children's Alliance, Denise Lester, Executive Director and CEO, Purchase Youth Village and Heart Youth Villages, and Paula Garner, Executive Director and CEO of Maryhurst Incorporated. If you all would, please introduce yourself for the record, and you have the floor. And you have 10 minutes, ladies.
Thank you. I'm Michelle Sanborn with the Children's Alliance.
I'm Denise Lester, the CEO of Purchase Youth Village and Heartland Youth Village.
And I'm Paula Garner, President and CEO of Maryhurst.
So thank you, Chairman Carroll and committee, for having us today. I had the privilege of speaking with you in August at the fair, and so I won't repeat everything that we talked about there, but wanted to make sure that we talked a little bit about the full continuum and the health of our full continuum. It's not about just one little unit for 24 kids. It's about making sure that we're healthy so that we don't get in a position where we're looking at this high acuity kids. So I wanted to make sure that you saw the list of the full continuum, and all of these areas need to be either developed or redeveloped. Some of them we had and then we've gotten rid of, and or supported and maintained. And I'll show you this again, the story of erosion and neglect is what's happened with our child welfare system. We need to make sure that we have intensive in-home services. We used to have the Impact Plus program, and many of those agencies were out in the community, in those families, and keeping these kids from going into hospitals and going into PRTFs. When we went over to managed care, we were able to continue those services in a different way, but the rates haven't kept up with the services, and so our therapists and case managers are dwindling, and we have a few agencies that are providing that intensive in-home services, and they're really getting donor dollars to really help provide that. Emergency shelters. We used to have emergency shelters for these kids to come into, but federally, there's really a war on residential and congregate care. They don't want our kids in congregate care. They want them in family settings, and so do we. So we've worked really hard in Kentucky to do that and really have moved away from emergency shelters, and we haven't really, again, supported that level of care, but it's needed. We need those emergency shelters so that when we remove a child at 12 o'clock at night, like they talked about, that's available. Obviously, we've got kinship care, basic foster care, therapeutic foster care. One of the things we've been talking about with the cabinet is intensive therapeutic foster care. So when we reduce residential, we have to have an option for those kids that need that level of therapeutic services. So we've been working with the cabinet on creating that system. Then the qualified residential treatment facilities, PRTFs, this high acuity youth inpatient psychiatric services. That RFP is needed. A couple years ago, and you'll see on my next slide, our agencies were calling and saying that the hospitals are saying these kids are too intense for them, but yet they're stuck in our community-based residential and foster care agencies, right? So I immediately talked to the Hospital Association, the cabinet, and I know they've been working together to try to develop something like these longer-term units that you've heard spoken about earlier. QRTPs, we have to support the entire program. They're financially struggling. In 2020, which is the last cost report that I had, almost all of them were losing money. The five that were not in the red, that didn't have the brackets around, were maybe $1,000, difference. On average, they're losing $700,000 a year at least. They're closing. And the kids that they're caring for are too severe for the hospital. And then PRTFs, same story. Over the years, we're not keeping up at the rates. They're closing, or being closed. And you can see the reduction in the number of beds that we have today, that we should be at about 300 beds, and we're not. Here's the utilization over the years for PRTF1. And then here's the number of kids that we're sending out in our DCBS population. So I just wanted to kind of tee that up before our providers talk about some solutions.
I'm going to get you to help me with this.
Yep.
For the sake of brevity, I'm going to skip quite a few of my slides today. So I want to tell you a little bit about who we are and what we do. I'm in Purchase Youth Village in Senator Carroll's area in Benton, Kentucky. And we are...
And I'm embarrassed to say that I have never visited that facility, and I would like to do that if you all are okay.
We welcome that. We welcome that.
Thank you.
Yes, sir. So we are currently a 24-bed psychiatric residential treatment facility level 2. That basically means that our kids have pretty much failed at other levels of care, and they need long-term intensive treatment for their chronic behavioral and psychiatric issues. This level of care historically was started to try to ameliorate this problem, there was only 164 beds, though, that originally were issued. Right now, we're the only PRTF2 open. Well, as of yesterday, now we're the only second. We opened Heartland Youth Village yesterday. So now we have 48 beds of the 164, and all those other beds have never been opened. We treat trauma-informed. We are a trauma-informed treatment service, and there's just a plethora of different diagnoses that we deal with. I won't go into that. All the disorders of adolescence. We can skip all that good stuff. Yeah. Clinical service challenges. This is one of the things in the regs that was challenging for us the first year, and I think that we're looking at maybe that is something that needs to be looked at in the future as far as it being part of the regs. The regs talk about home-like environment. When you have kids who are aggressive or violent on an ongoing basis, it's really difficult to have a home-like environment. We started out with that. As you can see, we had approximately $30,000 of damage within the first year to the facility, things we had to replace because of the nature of the kids' aggression. We have staff injuries. We had our workers' compensation paid 140. Is it 47?
It says 47.
47. My eyes are terrible. $47,000 in between 2017 and December of 2018. As a result of that, our rates went up, as they always do. Staff recruitment and retention is a big deal for us, as I think for everyone. But we are in rural Western Kentucky. It is very tough to find enough staff, plus staff who are qualified or have any previous experience. And then COVID hit and really damaged that. When you've got Walmart paying $14.50 an hour for people to sack groceries for online orders, it's tough to compete for those direct service positions. So that's been, if you ask me, our primary issue right now, it's staffing. Staffing is our primary issue. Per diem rate was established, it ranged between $345 and $405. That was not enough to take care of the cost of taking care of these kids. I will say I'm very appreciative that recently we got an increase on that to $600 a day, which is going to help tremendously in taking care of these kids. So thank you everyone that helped with that. We are very appreciative of those efforts, and Children's Alliance worked really hard and lobbied for us, and we were appreciative of that. So there were no benchmarks available because we were the only PRTF2. Reimbursement was difficult. They didn't know what to do with us with managed care. They didn't know how to bill it, what codes to use. It's very difficult, but we finally got that taken care of. We were the only ones around. There were no other residential programs within 100 miles of us. So the opportunities, we opened yesterday, Heartland Youth Village in Bardstown. 24 beds, and then we also have the ability to accommodate 22 more residents in the future. We'll take both males and females, 12 to 17 in Heartland. Be more convenient for families in Central Kentucky and Eastern Kentucky. We have kids that in our area or in our facility that come from as far away as almost in Virginia for care. And so this is going to make it a lot easier for families to be involved with treatment. They could actually come on site instead of just having to Zoom. Okay. I think we can skip that one. Okay. Yep, that's us. Thank you.
Okay. And I will skip through some of mine for the sake of brevity. I want to just thank you all for this opportunity to present. Obviously, I think we all share a sense of urgency on figuring out how to do this. We'll say that Maryhurst, our mission is to serve children and families in greatest need, and that has been the case for 180 years. We have worked really hard to uphold that mission. We have been innovators, first to bring trauma-informed care, and then with the 5S program, and I will talk more about that here in just a minute. We are also heavily investing in upstream behavioral health, where Medicaid rates do not cover that. And I just want to say my opinion is that in not covering those costs, we are, as a state, are laying the foundation for a mental health crisis for our next generation. Go ahead. So I'll talk more specifically about the 5S program. It was created to solve this problem, the problem that we have right now of children going out of state in 2011. Maryhurst contracted, and there was one other agency that contracted for boys, with Maryhurst being for girls. Started with 12 beds and has increased to more than 40 beds today, again for adolescent females. It is a program that works. We do have positive outcomes, which we review with the state regularly. We are currently serving 42 clients in that program today. We also have PRTF level 1. We are serving 9 clients there. And then in addition to that, we have 20 QRTP beds. So we are serving around 70 clients residential total. The population served, I think the secretaries talked very well about this, but they are, significant aggression, self-injury, and suicidality. And then we also serve developmentally, intellectually delayed clients. Often those also have medical complexity. Our staffing ratios, I've listed those, 1 to 3 at least, typically 1 to 2, and then we routinely staff clients one-on-one. We did pull in the numbers, and in 2023, we've had 18 clients deemed too acute for acceptance into psychiatric hospital. So that creates a safety issue for all of us. And I want to just stop there and say that is because of lack of capacity all over the system. So that is not the hospital's fault, but it is evident of the lack of capacity and the way that creates barriers and safety concerns for our children and our staff. So our challenges, which has been stated by I think every single group that has come up here, is maintaining that optimal staffing, especially with those who are frontline workers who are working day in and day out with our children. We have had 189 first reports of injury in our staff in 2023. 46 of these have required outside treatment. And that is significant. And I will, as an employer, I have a responsibility to our children, certainly, and also to our staff. And I know that in taking care of our staff and giving them what they need, we are going to be able to take the best care of our children. I have listed some things that we have done to stabilize the staffing below. Therapists, we are full. We do not need any therapists. And I believe that part of the reason for that is that is a first shift position. It isn't, typically a weekday position. And we are a great employer, but where we continue to have to struggle is those frontline staff, despite increasing salaries pretty significantly. We definitely have invested heavily in bonuses and other ways to recruit, and then in additional supports. So I do want to say also, I want to thank the state and the legislature for the money that has been appropriated for the 5S program. I could not be serving those 42 children today if those monies had not come to us, and I am extremely grateful. The other piece is physical environment, and I've heard several providers talk about that as well. But serving these children does provide very specialized spaces. It's also very expensive to keep up. They need to be very durable spaces, and there is a whole lot of destruction that you have to restore. So we also are working to open another PRTF1 and working with a partner who has adequate facilities for that. So that is a problem we are currently trying to solve on our own. And then I've had recent conversations actually throughout the time with CHFS and DCBS leadership. So some of our potential solutions that we are having conversations about is intensive wraparound services, as well as short-term stabilization for therapeutic state foster homes. Maryhurst was actually the first to provide therapeutic foster homes in the state of Kentucky, but we believe that we can be a partner to the state in that way. Also, any shelter or short-term residential, we are certainly willing to do, but we think they have been able to secure the needed resources there. And we are certainly open to looking at intensive residential program that we would build in partnership to serve those kids who are more intense than the 5S. Thank you all for the opportunity to testify.
Ladies, thank you so much for being here. Representative Decker, please hold your question, take note, and we'll get back to that shortly. And next we have Rick Worth, the CEO of Children's Home of Northern Kentucky Behavioral Health. Please introduce yourself and your guest also for the record, and you all have the floor.
Thank you. I'm Rick Worth, Chief Executive Officer at Children's Home of Northern Kentucky, CH&K Behavioral Health, and I'll ask my colleagues to introduce themselves.
I'm Crystal Loigers, Chief Programming Officer at CH&K.
Good afternoon. Julie Rea, Chief Strategy Officer, CH&K Behavioral Health.
Senator Carroll and Representative Heverin, thanks for allowing us to come in before the committee again and to talk to you. We put a man on the moon and we solved the polio crisis. We can solve this problem too. I think you have a room full of people committed to addressing this problem, this crisis that's before us. We have a PowerPoint presentation for you. I promise we are not going to go through it line by line. We don't have the time, but we thought it was important that we put it together for the sake of the legislators here. I'll begin simply by saying that the first two slides are trying to paint a picture for you legislators of who we are and who we are not. We are a behavioral health service organization. We have a total of 4 state licenses. We're probably most interesting to you today because we are a PRTF Level 1 provider and the only one to do that work in the northern bluegrass region of the Commonwealth. We are not a psychiatric hospital. We are not a secured lockdown facility. Part of trauma-informed care is a movement away from what's wrong with you to what happened to you. I hope the next few slides might help you legislators to understand here's the most exciting question that we hardly ever ask in trauma-informed care, and that's what's possible with these kids and what's possible with these organizations here before you today. I'm hoping that the PowerPoint slides help you to understand that for the last 2 years, we have been looking very hard at the question, what's possible with Children's Home of Northern Kentucky to meet the new needs that are before us.
So CH&K is also a collaborative partner with the Cabinet for Health and Family Services and the Department for Community-Based Services. And we do that in the following ways. We have earned a designation as a Qualified Residential Treatment Program. You've heard the acronym QRTP. We are engaged in providing family preservation to families in home to ensure improved functionality of the family and keeping kids out of home placement. And we also recently joined the pilot program to provide multisystemic therapy, again, serving older adolescents with criminal involvement. And most recently, we have been working with the Cabinet and proposing some ideas for bringing youth who are hard to place into our care. At this point, there hasn't been any interest expressed in our most recent proposal, but we are looking forward to further discussions. Let me see, page down. Very quickly, in seeking solutions, what we have done most recently, well, actually 5 years ago, we opened our first PRTF Level 1. We are the only PRTF in Northern Kentucky. That was for adolescent males. Just last week, we opened a second PRTF, and when I say second, there are 2 units, so a total of 18 beds to serve adolescent girls. We also, this past summer, started a partial hospitalization program to try to help meet the needs and keep these kids out of residential. And of course, we're looking at a capital campaign to try to expand mental health access to youth throughout the 12 counties of the region.
In terms of discussing specific placement challenges, we evaluate each client based on their presenting issues and then our areas of clinical specialty. We would not be a responsible provider if we were able to provide services to all youth because we want to make sure that we have clinical specialization in the areas that youth is presenting with. Also at the forefront of our mind, of course, is looking at youth safety and also staff safety. Of course, financial considerations is not the only consideration as we evaluate the resources that we're able to provide, but it does allow us to be able to invest in areas of specialty to kind of widen those margins of access and availability within our beds. Every other facility has discussed, and we would be remiss if we did not, that staffing continues to be a significant issue as we evaluate bed capacity. So we have 18 beds on 2 different PRTF units. One specifically is serving females, one is serving males. And in order to fill up those beds and be able to take more youth, we currently have 20 residential treatment specialist vacancies. So those are the staff persons that are working day to day with each of those youth and managing routines and providing behavior modification support. As we think about solutions moving forward, as I mentioned, of course, staffing continues to be a challenge. We also think about areas of specialization, and so we did submit a proposal to DCBS regarding opening up 8 QRTP beds. We've not yet heard back about that proposal. However, we certainly would consider a subset of that proposal. A number of facilities have discussed kind of what the presentation of these youth is. And in our experience, this is not a child that can fit into the traditional milieu with the other youth. It's a child that we need to modify the external environment around them to support that child and keep them safe, and also keep our associates safe. So we feel like that needs to be several staff per child in order to provide them with support. The other piece, of course, is having a community safety net, which again, another provider had talked about, but looking at law enforcement support, acute hospitalization in the event of lack of safety, and also the availability of foster care homes. Our youth, like all of us, right? If we don't have something to look forward to, then the behavior becomes exacerbated. And without the possibility of step down into a foster home, we see that behavior certainly upticks.
So, Senator Carroll and Representative Heverin and members of the committee, to quote Jim Collins in the Good to Great movement, we are trying to maintain the core of things that we have been doing for decades for the Commonwealth, but we're also trying to grow the margins, and we're trying to focus on growing those outpatient services and move upstream so that we don't have the kind of severe issues that we're constantly dealing with, it seems, here. But I just wanted to, I'm thinking if I were a legislator, what would I want to hear from a provider that would be worth my time? And let me just, I know my Northern Kentucky legislators already know this because I'm blessed to have them at the Children's Home on a regular basis. But I will just conclude our comments by saying all of this work that we're trying to do, it's not being done in calm waters. This work that we're doing is in turbulent waters. And it is, we have 47 years of dedicated experience to CH&K, the three of us do, 47 years. We're not in it for power or prestige or property. We're in it for the right reasons, but it can be daunting work. And let me just paint a really brief picture of what that daunting nature of our work can be. Abby Drain was very transparent and talked about the pain of having lost a child. We have too. June 2022 was the worst month of my life. We lost a child at Children's Home of Northern Kentucky. We've been in existence for 145 years. We have never dealt with that. And we are still reeling with that tragedy. And you can imagine the shyness that evokes in staff while we're trying to talk about what to do with higher acuity youth. I'll also tell you this. I look at you and I know that you're sincere in wanting to solve this problem. But I hate to tell you that there are other people out there in the Commonwealth who aren't so gung-ho on what we're doing. I can tell you about the problems that we've had with neighbors at our Burlington campus since the day we moved out there in 2010. People did not want us out there. I can tell you about a neighbor at our Burlington, Kentucky campus who got out a shotgun when he heard that there was a child who was eloping, and he started shooting his shotgun because he thought he was going to be helpful and scare the child back into the property. I can tell you we ordered pizza for the kids, and the same neighbor got annoyed that the pizza driver pulled up in his driveway by accident, and he got out the same shotgun and shot over the pizza driver's head. I'm not trying to be dramatic here. I'm just trying to help you to understand these are not calm waters. There are people who are not so happy. I hear comments all the time in Northern Kentucky. Why are you bringing all of these problematic kids into Boone, Kenton, and Campbell County? So I just want to paint that picture to you that we are committed to being problem solvers with you, but the stakes can be very high for providers. Thanks for taking the time to listen to us.
Thank you all very much. Chairman Merritt, if you would hold your question. We have one more presenter, and then we'll get to questions. Megan Ackerman, the CIO, Chief Innovations Officer for Holly Hill Child and Family Solutions. And ladies, if you would, please introduce yourselves for the record, and you have the floor. You have 10 minutes, please.
Thank you. My name is Megan Ackerman. I'm with Holly Hill, and I have our board chair, Erin Wilkins, here with me today. First, we want to say thank you for taking your time today to kind of consider all the levels of this systematic issue that we're dealing with to serve and help the kids heal in the state of Kentucky. Unlike other residentials, Holly Hill is small. We're small. We're a 2-cottage facility. We're not necessarily looking to build other buildings. What we do want to do is specialize, and we want to be able to specialize in victims of human trafficking and grow our work in that. Sorry, I can't get my slideshow to play. That arena. Much like CHNK, we've been around for a very long time, as you've heard from several agencies. We are deeply rooted in serving the youth of Kentucky. We've been one of the oldest agencies in Northern Kentucky focusing solely on females in a residential setting. We're one of the first pilot QRTPs. Our current focus and why we're here today is because we want to fill the critical need of supporting youth in the state with complex mental health needs. These are not youth that are easy to care for, as you've heard. These are not youth that are going to be treated in a month or 2 months or sometimes even 6 months. These are youth that are highly traumatized. These are youth that need lots of dedication, support, care, and love. We want to increase our census by 200%, and we can do that with our current physical structure. And we want to focus our work on confirmed and suspected victims of human trafficking. We want to keep youth out of alternative placements. We also have plenty of preventative services and outpatient services that we continue to try to grow so that youth don't have to be in a residential setting at all. If we could keep them in our community, we would be extremely happy. I want to take a little bit more time to kind of talk to you about who we serve. I think this problem has been explained and a lot, but maybe not as specifically as we are seeing it. So we serve females ages 11 to 17. 100% of our females are unable to be safe in their home environment. They've been removed from their home for reasons that were not their fault. Adults have done horrible things. 100% of our youth have a history that's confirmed of physical and verbal abuse. 40% of our youth are suspected or confirmed histories of human trafficking and exploitation. 40%. When you're a small program and more than just about half your cottage has been exploited and had a consistent history of adults buying their bodies, they do not treat you as an adult in the same way. Their behaviors are different. We are not treating sexual abuse in the same way that we have before. The average ACE score for our youth is 8. These are complex experiences that they've experienced from early childhood to when they enrolled in our program. Often they've had a history of hospitalizations and placement disruptions. We have one youth in our care right now that's been in 22 placements, and they are 12. When we talk about attachment and staffing issues, every time a staff leaves Holly Hill, that youth experiences another difficulty in their life. And they don't want to listen. They don't want to follow rules. They don't think you have their best interest at heart, and they definitely don't want to continue talking about their trauma when they've done it over and over. Yet we're going to rise to that challenge at Holly Hill, and we're going to help these youth tell their story, process their trauma, and allow them to live successful lives outside of a residential setting. I agree that shrinking the population of residential is a good thing for Kentucky, but there is still a need for specialized services. Our clinical acuity, like I said, is not what I would have imagined 5 years ago. We have seen since becoming a QRTP and since becoming a specialized human trafficking agency, our suicidal behaviors are ones with plan and intention, and they are creative. Our kids are the most resilient kids. They can survive most anything, and they can solve all the problems that they see that maybe we don't. A really good example of this is our cottages were built in the 90s. They have traditional windows like in my house and your house. Yet our kids with constant suicidal and ideations and negative thoughts see those windows as an opportunity to break them, to take tiny glass shards or large glass shards and injure their bodies. We've had youth outside the cottage window digging through the mulch to find little glass shards. so they can hurt themselves, because in that moment, that is their solution. That is what we're trying to work through. This is why it costs a lot of money to keep facilities up. This is why infrastructure has to change, because we were not designed for this level of care, but we want to meet the challenge. Our kids are also in a constant state of survival. Fight or flight response is 24/7 when they first join us, and when they leave us, it's probably still 25% of the time. But that's a huge gain. They see things and they have paranoid thoughts, and they're concerned for their safety because they've lived in horrible conditions where they had to be concerned for their safety. And sometimes they see everyday objects as weapons for themselves or others. We had to remove landscaping rocks because they became weapons throwing at a kid that they thought looked like somebody that hurt them once. And that's a real experience. We also, because of our work in human trafficking, have experienced sexual and behavior groomings of youth that is different than before. Our youth come to us thinking that only healthy relationships are romantic and sexualized in nature. They don't understand if I don't comment on their body, or if I don't want to have tight hugs, that I'm not going to care for them. They have been groomed in a very different way. And we need staff who understand this and can get the training and continue to want to work with that youth every day. We make very difficult decisions as we rise to this challenge. We are working with DCBS to preserve and maintain placements throughout hospitalizations, after 2-week notices. When nobody else will take that youth, we are keeping them. We had one youth that we maintained in a cottage of one youth. We supported a whole cottage for one youth for over a month because their sexual reactivity behaviors were too high for any youth to even be around them. A whole cottage, a 12-bed facility for 1 month. And we only got to bill on that one youth during that entire time. These are the difficult decisions that we're willing to make, and that our board is here because they support it, because it's the right thing to do. But we can't sustain it without help. We've also created smaller caseloads for our therapists so they can offer hours, sometimes 10 hours a week of clinical therapy for one kid in crisis working through it. We've created staffing ratios of 1-to-1 and 1-to-3 to ensure that they have constant therapeutic supports. Very rarely are we over 1-to-4 in our staffing ratios. We've also moved double bedrooms to single bedrooms. We're still licensed, and our utilization review will show that they're double, but only one kid can be in there at a time because of their behaviors, because bad things happen to them at night, because when people are in their room, they got hurt. This is what we do to support and work through the behaviors that they're experiencing. And I don't expect people to quite understand it. That's why I wanted to come here today and really talk to you about, when we talk about infrastructure and we talk about the high acuity, what it can really look like. It is heartbreaking. It is heartbreaking to be able to view a window as a form to complete suicide and hurt yourself because your pain is that big. Medication therapy is going to take time to work, and we want to do that work. We want to be supported by the state to do that work. We understand that this is a systematic issue. It is at all levels, as you've heard from many of the community providers here today, and everybody seems very willing to collaborate and meet the need. It's about coming up with that comprehensive plan that supports each level. You know, as a specialized QRTP, we need the ability to use hospitalization. I actually have a young person placed in Sun right now because their behavior was too acute to maintain safely. They were so acute that we couldn't even transport them in a vehicle. We had to get EMS and law enforcement. We also need foster care homes that are trained and willing to work with the youth when they discharge. We provide family therapy to foster parents the moment they're identified, and we continue that work for months after that they are discharged so that they understand how to meet that kid's needs, because transitioning from a safe setting to an unsafe setting is still a difficult thing to do. We need more infrastructure to support our foster care families as they transition so youth can maintain in that placement and not have another disruption. We also need to understand that youth have to be at the correct level of care. Often when they're at the incorrect level of care, you see regression, or they're maintained in a way that doesn't support the continued healing process. We see innovation as a solution, and we see that Kentucky can rise to it. As one of the first places to implement Family First, we know we could do this. Infrastructure and critical investments have to happen across all the continuum. At Holly Hill, we want to optimize our current resources without building new cottages, but we need to change things. We need windows that don't shatter. We need doors that have badges for quick entry instead of keys. Like, our facility was built in the 90s and still looks like it, even the Art Deco walls. As a specialized QRTP, we want to stay in the arena of victims of human trafficking. We want to specialize and dedicate a safe place for the youth of Kentucky to come. The problem of human trafficking is here. Youth are being commercially exploited, probably more frequently than we know. 1 in 4 homeless youth report that they were exploited at some point in time. Please let us be that. And we want to collaborate with other partners to continue this work. So our ask is that you look at the proposal that we have, and we have one with ECBS too, and then continue encouraging collaboration and a deeper understanding of the needs. Thank you.
Okay. Ladies, thank you so much. We're going to go back and pick up some questions. Representative Fleming, who did you want to address your question to?
Thank you, Ms. Chair. First of all, I want to say thank you to you and Co-Chair Heaven for solution. I appreciate your aggressive approach. My question is directed to Brookline. Yeah.
Yep. Please just have a seat.
You know, Abby, you don't need to bring up your PowerPoint, but I'll point it out on slide 5. At the bottom, it says license appeal has been pending since January 23. And then on slide 8, you have capacity versus actual. And it ranges over the past year from 31 to 42. And then on slide 9, you have a capacity of 150, where it actually is around 28. The secretary came up and mentioned about 38 individuals have gone out of state and so forth. My question to you is, could you explain to me why this is still pending when you have the capacity to do this in order to help alleviate some of this pressure and situation?
Yes, sir. That's my same question, too. We don't know. We haven't gotten a response. The last response was in September with my legal team that the cabinet hadn't reviewed our response yet. I think it's a travesty because if you'll see a direct correlation in our beds going down and number of beds going up and out of state and in other placements in DCBS.
Has there been any communication to you whatsoever?
Not around that. No, sir.
Okay. Mr. Chairman, I'd like to see if the secretary, not to put you on the spot, or at least maybe offline, to contact her to get a resolve, because this is, I mean, they've got the will, the desire, and the heart to get this resolved, at least make a pretty good dent in it. So if we could expedite that process and review to get them licensed back on the line, I would appreciate that. Thank you, Mr. Secretary. I appreciate it. Thank you, Abby. Thank you, Mr. Chairman.
Representative Decker, who was your question addressed?
I think it was to the last 3. Rick Worth, perhaps. Was he one of the last 3? Whoever said they had 47 years of experience. Thank you, Mr. Chairman and Co-Chair, for bringing up this topic, and thank you to all of you who testified today. Can't imagine anything more important than what you do. I had a family member who worked in this area, and I know from her, I believe that probably every one of you are the same as she, and you want to help with all of your being. You have committed your life to this. Thank you for that. My question is, in your 47 years of combined experience, do you have an idea, is this getting worse? Are our children sicker? And if so, do you have a diagnosis, or I think I heard someone say there are various diagnoses, but what is driving this?
That's such a great question and such a difficult answer. But I've been at CHNK for the last 10 years, and yes, I would say that the acuity of the youth that we're seeing and the referrals that we see is significantly increasing. I'm sure there's obviously some quantitative and, of course, qualitative analysis of that I can't specifically speak to. What I will say is that the presentation of prenatal exposure to substances, in my experience, has dramatically increased. And, of course, that exacerbates the presentation of these youth because of impulse control issues and also the potential for aggression. So that is a difficult population to serve. Also, the responsiveness to medication definitely is altered based on brain chemistry exposure.
Thank you. Are there other things, or is that primarily what you see?
In terms of the presentation of the use?
Yes.
I would say in all categories, the severity of what we're seeing has increased. The other piece in terms of our service population is there's a reduction in family involvement. So a number of our kids have no family. We have something called a contact list, so people that they can call in the evenings. And the amount of children that have no one on their contact list, that has been a really significant change in my 10 years of working in residential. The other piece is the availability of foster homes. Even when we were serving very high acuity youth with perhaps sexualized behavior, aggression, we always had the opportunity as a clinical team to evaluate potential foster placements, to potentially talk through that with youth, to have a number of visits prior to them returning to that foster care placement. That's changed. So now when we're notifying DCBS or we're collaborating with our partners and saying this child has discharged from our facility, there are no foster homes. There is no discharge planning process. And that's not the fault of anybody. It's a systemic breakdown because there's not foster homes like there were previously.
Thank you, and thank you for the answers.
Chairman Meredith, who would you like to address your question to, sir?
Probably Secretary Freelander.
Secretary.
As he's coming to the desk, I want to thank all of our presenters. It's been very informative, and Mr. Chairman, I want to thank you. I think this has been a great discussion, and I commend you for bringing so many people to the table to talk about the resources available to us. And Mr. Birdwhistle, I really appreciate your comment about it's a much bigger problem. We need to bring all the parties to the table. When we talk about foster care, it looks like we kind of take a snapshot, the picture in time. It is much broader. Foster care, kinship care, I think offers an opportunity. Fictive care does as well. And we need to have a more comprehensive approach to this rather than piecemeal like we have done. And that's not a criticism of anyone here. I think everybody's done a great job with the resources you have available to you, and you ought to be commended. Secretary Freelander, you made a comment about in some instances out-of-state placement is kind of imperative. It's better to do it there. Can you elaborate that on just a little bit?
I'll give you an example without trying to make it so specific that it's you'll be able to identify. But there was a person who was in out-of-state placement doing pretty well. And the imperative years ago was to make sure we had everybody back. What happened then was there was a placement disruption, right? And you've heard about how difficult placement disruptions are. That person had been in the out-of-state facility probably for 9 months, I think around that time. Came back, placement disrupted, the services that person was receiving went away. Came back to Kentucky, had that separation, got into a cycle of acting out, got into a cycle of psychiatric hospital, therapeutic foster care, psychiatric hospital, eventually resulting in a level of violence that ended up in Secretary Harvey's, with Secretary Harvey's group. So there was a time when that placement was working. So that's the only reason I say that. I think I've seen, and I'm giving you an example because that's the example I know of, that one. But I'm sure there may be others where disrupting the placement, even in an out-of-state facility, could be harmful.
This situation reminds me of my favorite riddle, which I know I've shared with you on numerous occasions, about you got 5 frogs sitting on a log and 3 decide to jump in. How many are left? Well, it's 5 because deciding to do something is not the same as doing something. What I've heard from everyone here today is everybody wants to fix this problem. I guess the question I have is, if we want to do it, and other states have done it, why can't we do it?
Well, first, I'm not sure. I think I could give you examples in most other states that are what we're experiencing here. We've seen it, and as I talk on the national level and with other state partners, other states, many are experiencing this. So I think it is a crisis of our systems, and and it is we have to reimagine our systems. You've heard already the folks we're seeing, and I believe I've testified to this as well. Who we are seeing, those children who are coming to us are more acute. There's no question about it. I'll even add one, right? During COVID, we didn't have eyes on kids. So the kids that were in bad situations, it got worse. And we did childcare, church, school. We didn't have eyes on those kids. So if they presented then again on the other side more acute. That's true.
Oh, I would agree with you. It's not just post-COVID. It's an indictment of society today. And we've got to address some very fundamental problems. But I ask the question again. I hear folks here today want to fix this problem. They're willing to fix this problem. Can anybody give us something tangible and say, if you do this, 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 and this, we will do this service? Can anyone do that? Will anyone do that?
I think we're all trying, and we haven't found the right solution yet. I think I have testified. We tried what essentially is called a single case rate, which is where we'll pay, and we'll work with the MCOs and we'll work with the provider to pay what we need to pay for services. That hasn't fully taken because it's so one to one that it gets hard to figure out how to do that with some of the facilities. And some of the facilities and some of the partners, it's hard to come up with a long-term strategy unless we're paying for beds that maybe aren't being used. And that's something that we're looking at. I signed recent contracts around, you heard, some of the emergency shelter pieces where we need some of those beds to keep those kids who are coming through quickly. We tried an RFP that some folks didn't like, so now we're going back on an individual basis. I think expansion of 5S, and I think some of the discussions we're going to continue to have, I don't doubt the heart from just about everybody in our community. I don't doubt the heart, and I think we can come together.
Well, you mentioned you're disappointed about the RFP, and I think we're disappointed as well. But maybe we need to take a different approach to this from the folks we've heard today. It's just, you folks tell us.
Yes.
What will it take to get this done? And I think you can tell by the questions and comments we've had throughout these committee meetings that we're willing to do pretty much anything, but you need to tell us what it takes to get it done.
And we're willing to do just about anything as well. So I think we have the basis for agreement.
Well, I think that's a challenge that we have is an RFP kind of comes from us. Here's what we want. Let's kind of flip that and say, tell us what it takes, and then we can address it. It's kind of you're giving us the RFP rather than us giving you the RFP. So thank you, Mr. Chair.
Thank you, Mr. Chairman. And just to kind of fill in a hole here, I had a conversation with Nancy Galvani with the Kentucky Hospital Association, and I came out of that conversation very optimistic, and she feels like from the hospital point of view, with the acute psychiatric hospitals and the PRTF level 2, they are very optimistic that if we focus on that, we can make a huge difference in dealing with the emergent trouble that we're having, the crisis situation with those highly acute kids. And I didn't expect that when I spoke with her at all, but I feel like, and Mr. Secretary, correct me if I'm wrong, so if we, and I get the impression that there are many hospitals that are willing to develop programs, the psychiatric programs, and even the PRTF level 2, that they're willing to participate in that. It's just a matter maybe of restructuring the regulations. And if I remember correctly what I read, when PRTFs first were proposed, there were 8 different organizations that wanted to open up one of these facilities, and then when the MCOs came on board, kind of all that fell apart. And I'm sure it's more complicated than that, but that's what I read on them yesterday. So if we are able to expand the psychiatric hospitals, those programs throughout the state, and that deals with the immediate emergency, and we maybe don't force all of those hospitals to take any child that we send them, but maybe designate 1 or 2 hospitals that have an even higher level of care and facility to address those children. That takes care of that level. And then that takes care of the immediate crisis. And if we can go back to this PRTF levels 1 and 2 and continue to grow those, that's going to take care of the longer term for those more highly acute kids. And that in itself will probably take care of most of the immediate problems that we have, and then continue with QRTP programs and make sure we have the emergency shelters. Is this soaking in my head properly, or are there gaps in between my thoughts?
I think that is a potential pathway. I think we got a system that we need to really take a look at some overhaul. I believe the challenge on the highest acuity, those kids that are the highest acuity, I think the challenge will be to make sure that we can have placement for them, right? That was the rub on the RFP. That continues to be a bit of the challenge, which is how can we assure that these most challenging kids, you heard 3-to-1 staffing ratio, folks worried about staff safety. How can we assure that somebody will take care of those kids? I think that's the biggest challenge.
I think if we search and if there is compromise, and I think if we don't try to force every hospital, the psychiatric program, to do this, and we focus on 1 or 2 hospitals, and we help provide the funding to make that happen, and we're not talking a lot of kids.
Right.
So to me, that seems like a way through this, and I don't think for right now, I don't think we can focus on this whole continuum of care like Michelle spoke about. Mm-hmm. We've got to. The purpose of this is to focus on the immediate emergency, and I think that's what we've got to spend our time on today. In a month from now, we're bringing the kids out of state that we need to bring home, bringing them home. The kids that are in DJJ, we have a place for them to go. The kids in DCBS, we have a place for them. That's what we've got to get done in the immediate future, and then we can branch out from there for all these other issues. But that's kind of what I'm hoping to see. Co-Chair Heverin, you have a question, ma'am.
I do. Chairman, will you indulge me in 2 questions, please?
Yes, ma'am.
As a follow-up to Senator Carroll and Senator Meredith, what happens when these kids age out and no longer meet the level of care in a hospital setting?
A variety of things. Some of these kids, we know. My time working in homeless services in Louisville, some of these kids age out to the street. That's just true. Some of these kids, when they become adults, can sometimes quickly face charges. Sometimes these kids who are in a strong case management system can continue to receive services, but I'd say that's the exception. I think my earlier description of what happens is what happens.
So it sounds like something that we might need to work on. It sounds, and I think that's been an ongoing conversation, that there's a cliff after foster care. No matter what type of setting that you're in, that there's a cliff that happens. So that's a good conversation to continue having. My second question is back to of kids sleeping in DCBS offices. How do you all document the care and services that are provided for children in the offices?
Let me bring Commissioner Dennis up, if I may.
Absolutely.
Secretary Harvey, will you check your phone, please?
So each of the youth that are in a non-traditional placement, we track those kids. We have, and of course we have a tracking system for that. But then we also, each of our caseworkers they document ongoing in the case record about the needs of these kiddos. They also have available just a log within our locations in which they are sharing information between them. So if you do a 4-hour shift and the youth had no issues at the end of your 4-hour shift, you're documenting if everything went fine, so the next worker can see that. And then if there's concerns, then they're sharing information among each other regarding how that child is doing. But the documentation primarily is going to be the ongoing case record. And then, like I said, we are tracking each of those kids.
And you had to develop that.
Yes.
I think the point is that it didn't exist until it became so prevalent for us that we had to develop policies and procedures and how we document in our system so that we can follow that. It's what? How old?
Within the last year and a half.
Yeah.
So, I mean, there's information on the kid, their diagnosis, their medication. I mean, all that information is available for each worker who's providing supervision and care for that youth. And then they're keeping an ongoing running record of the day's activities, what that looks like, behaviors, concerns, etc.
So if they are being housed by DCBS, are they still receiving services that are required?
So we've been doing some work in that space as well. Ramey Esteb has been working with us to provide some telehealth services for children that are staying longer than a few days. They've been doing that in the northeastern region consistently, and then we're currently in conversation with them about how to do that across the state. So most of our kiddos are there short periods of time, 1 to 4 days, something like that. But for those that are staying longer, we definitely need to ensure that there's services put around those, and we're working to establish a consistent way of doing that.
I think my concern is what happens if they need services and they're not receiving them, because it's a form of neglect upon the state.
And some of them they're in their community, so if they're still in their communities and have access to their providers, they're still seeing them. And we're getting them to those appointments. We're working to make sure that they have access to needed services through different means.
Would you all consider, if they were at one of the groups that talked earlier, if they weren't receiving the services, would that be considered neglect for the child? I don't want us to have a double standard, I think is my point. If they're not getting services within the children's homes that they're in, and we're not giving them services in DCBS, that's two sides of neglect. So as we move forward in these conversations, yes, I just want us to consider that, because we don't want to, we can't slap people on the wrists for neglecting children while we are doing the same in-state care. And so that would be like an ongoing conversation I would like to have with you all. That's it, Chairman.
Happy to have that conversation, but I hope you did hear, if they're in the community and they're have a care plan, we are making sure that they get that.
Right.
My concern is if they're not in the community and they're not receiving the services and having the care plan, what does that look like for them?
Okay.
Thank you.
And there is a case that I want to talk about quickly that talks about aging out. And those of you who were involved and tracked the DJJ issues last session, and you all remember the one female that we talked about that was in a facility that spent most of her time nude. She would be sleeping in feces, not really getting much treatment. They tried numerous places. No psychiatric hospital would take her, even out of state. There was no place for her to go. The only way that this young lady was to get treatment was to turn 18 years of age and end up in Western State. And that my understanding is that young woman is reacting to treatment, is making some progress. If there is no other scenario that makes it more clear how badly we are failing in this Commonwealth, it's that one. Can you imagine the damage we have done to that young woman being in that cell and not being able to provide her treatment, and she had to age out of that, and she's an adult, and then all of a sudden there's treatment? That makes no sense to me whatsoever. What are we doing? What are we doing? The answers are here. And I a few days ago, I felt a sense that of desperation with this, but hearing what I heard today, my conversation with Nancy, the answers are there, and the assets are there, the capacity to address this, it's there. We've just got to get the policy right, and that we've got to move on it. We've got to stop planning on it. We've got to stop having discussions. We got to do it. And I guess maybe that's my flaw as a leader in my organization. I don't do 3-year plans. I don't do 5-year plans. We just do it. And I think that's where we are. Representative Raymond, who would you like to address, ma'am?
The secretary will work for me. Thank you. A quick question and a comment, please. We've had some good examples today of what danger to self looks like, of what danger to staff looks like. I want to ask you what the euphemisms acted out sexually and sexually reactive mean. Those have been used quite often. I really cannot picture a situation where a child needs to be alone in a 12-person cottage due to this issue. Can you please make it more clear?
I'll defer to you.
That's a very good question, very complex question. So if problematic sexualized behaviors can be a lot of different things, but I would imagine they are a threat to sexually perpetrating on another youth within that particular youth. That the concern was that they were going to perpetrate, act out sexually with other youth within that setting, and then there are children who have. Within that problematic sexualized behavior category, who have been victims of child sexual abuse, and then they act out. They have sexualized behaviors that are inappropriate, that can range anything from just inappropriate in a public setting, things that they may do, all the way up to actually perpetrating on someone else. As I said, it's a range of behaviors.
Thank you. I know people are being careful with their language today, but if we don't understand the scope of the issue, it's difficult, I think, to act on it. It sounds like, and I was thinking the same thing that Chairwoman Heverin was thinking, that when they turn 18, what happens to them? And I imagine, based on the testimony today, that the vast majority are institutionalized, homeless, or incarcerated. And my concern is that many of these children who are sexually reactive, to use that phrase, right, become our sex offenders in society. And when they're 17 years old, we love them. Everyone in this room loves them. We're talking about how much we love Kentucky's children. And then they're 18 and Kentucky does not love them anymore. So I'd like to work with some of my colleagues on this bridge program that it sounds like we desperately need. Thank you.
Okay, I do not see any other questions. I can't thank you all enough for coming to testify today. For providers, we will be in room 269, and want to advise committee members that our next committee meeting of the Interim Joint Committee on Families and Children will be on Wednesday, December the 13th at 10 a.m. in room 154 of the annex. And if there are no other comments, we'll entertain a motion to adjourn.